Hey everybody, welcome to this edition of Treatment Trends. Today we are talking about localization and the impact that is having on the space. So real quick introductions as always, I'm Nick Jaworski, CEO of Circle Social Inc. Jacob?
Hey, I'm Jacob Lynch, Stone Ridge Partners. I head our treatment center space and we focus on mergers and acquisitions, home health, hospice, and behavioral health.
James and Kathy?
Go ahead, Kathy.
Hey, I'm Kathy Frostert. I'm a Vice President of Marketing and Business Development for Foundations Recovery Network.
And I am James Hadlock. I am the founder of Blue Novus. We help treatment facilities improve their call handling and close rates and work with corporations in more effectively addressing addiction and mental health in the workplace.
Awesome. So appreciate everyone here joining us again for this edition. We are talking about localization. And what that means is there has been a strong flyaway model in the space for a long time, right? A lot of people flying from New Jersey to Florida or from, Oregon to California, whatever it is. And so I think we're all seeing that this is not necessarily a sustainable trend for a lot of programs. So let's first kind of just jump on the topic of, what are people seeing overall? How are we seeing this change, or are we seeing this change, from everyone's perspective?
I'll jump in. So I think it's interesting. What we started seeing as a change was just how many people's insurance would now start paying for treatment. And because of your insurance, you might be required to be in a local area. And so that makes a big change. And it's kind of interesting because insurances didn't really cover that much before, and they're beginning to cover more and more. In some ways, less and less in others. So I think it just creates that vacuum of needing to look at that radius around you instead of national.
Can you explain that a little bit? What are you seeing in terms of them covering more?
So I think what we're finding is that they'll cover step downs or step ups in care. So the point of entry changes. And the point of entry before seemed like it was always residential, but now the point of entry might be an IOP. And then if they need a step up in care, then they'll go to residential. And so there's more of a flow to it, the way the insurance will cover more in that way. And then if I can flip it on the other side, if we just go directly to the highest level of care, they cover less. They're less time frame that they're actually covering. But one thing's for sure is that if your insurance only covers in network and you're working for a smaller organization, it's only going to cover in the state that you're in.
Yeah, that's a really interesting change, right? And I think also we're seeing the higher deductibles on the PPO policies. So even if you do want to use your PPO, it might not be financially, it might not make sense for you. James, Jacob?
Sure. So I actually had a conversation about that this morning, looking at the map over here we've got in this room, but somebody was telling me about one state where their Medicaid basically was paying Care Act before, and so they wouldn't let them go out of state to use it since they're paying for it. So if you're going to take our money, you're going to get treated, and you're going to stay in our state. I think we see those sort of things a lot more often, which makes sense from the state standpoint. And that's on a Medicare, Medicaid level. But regardless of it, as this industry started years ago, and I'm no clinician or haven't been around that long, but I believe, it was always you're going to get treated, go someplace that you're away from all the influences and you're in some serene setting and so forth. And I think nowadays you're just realizing that a lot more people have an issue. And to get that treated, it's not very feasible or convenient for a lot of them to be gone for, 30 days plus, whatever it might be, to somewhere that's not home. Or they might be embarrassed and they might not want people to know that they're gone for that. So maybe it's a thing where they are checking into someplace over the weekend, taking a couple of days off, getting detoxed, and then coming back to something that's very local to them to get treated in an outpatient setting. Either way, I think the localization piece is much more convenient and definitely here to stay. I see buyers all over the place in my industry that are always looking for a large full-scale platform in more and more places, right? So it might have, an old model, I would say, it might have used to have been, we have one large setting, one large center, and then a bunch of different smaller places all over that facilitate things. Well, now I think they're looking for more of a full-scale, full continuum offering and more places to serve more people that don't want to travel across the country to get the treatment they need.
Yeah, I think you're right. Driving the financial piece does drive a lot. And sometimes it's from the insurance end, and sometimes it's just from the flight end, right? Not too long ago, all these centers were paying for flights. And now it's basically illegal across the entire US to pay for a flight, right, as an inducement. So centers, if I've got to pay $1,000, right, $400 there, $400 back, that's a big disincentive for me to travel out of state now. James, what are you seeing?
Yeah, well, that's where I was going to go with this. Being more on the marketing and admissions side is, now that we can't or shouldn't be enticing by paying for those flights, I think you're going to just naturally see in the marketplace that's reduced significantly. I'm always interested because there are a lot of teams out there, right, that have representatives in all kinds of other states. And I'm really interested to see how that does change just simply because you can't pay for flights. And what's that going to mean to, how do you market now? Like if you're in Utah, which is where I'm at, and you've got a facility in Denver, what does that look like today? Is that, are you needing to change your messaging? Are you, what are the needs of the client? And I go back when you were talking, Jacob, one of the first things I think about is what's the real need of the client? Not what is my need. Maybe a novel idea, right? But what, but what would be the most beneficial? Because there may be, what if you have, people in your community that it's just not at the time advantageous for you to attend some kind of treatment in that area, because most facilities go outside of their facilities for 12-step work or whatever the case may be. Maybe it really is in their advantage to go somewhere else. And so I always want to ask this question very, very, very first, no matter what the situation is. What's the need of the client first? And let that help drive that decision versus how can I sell them on what I've got?
I think it's interesting what you're saying and leading kind of into the next question in terms of patient needs, but also how does that translate to our community and the need there, right? Like if I have a 20-bed facility, why would I need to go out of state to find patients, right? I mean, are you telling me that if I live in a metropolitan area where there's a population of 1 million or more, that there's not 20 people a month that need addiction treatment services, right? So it always begs this question of like, what's going on? Why are we not being effective in our own backyard? And on our end, we've seen it in the data. I'm sure other people have seen it with their centers too, whereas if you have a business development rep, where you have a treatment center or nearby, you'll see about 3 times the number of referrals that lead to admissions versus if you're across the state or really far away. So from a business standpoint, it makes more sense to stay closer to home because it's more effective. But then again, I'm always asking like, why can't you bring in people locally? Yeah, I mean, I think part of it was just the oversaturation, right, of certain areas of the country where they did kind of have too many beds for a particular county. So then it doesn't work. But if you're not in one of those over-concentrated areas, you should definitely be able to service your community. And that's going to lower your overall marketing and operational costs anyway. So other people's thoughts on kind of that idea of how do you serve your local communities and be effective there?
I've been working on that a lot because, as you guys know, Foundation's really marketed on a national level and with a national call center. And I completely flipped that on top its head this year and started focusing on the facilities. And I think one of the reasons I identified with why community and localization is so important is because people don't trust. There's no trust because of the media. So you need to create that community trust. And I think it's a little bit different than just a traditional business development role. I think there's a second role, and that is being a part of the community, and that is going to get you more referrals. And so if you just put in a bunch more BDs and you don't really look at what your needs are and what the community needs are, then all you're doing again is just hitting up treatment centers or hitting up therapists, and you really should maybe be out in the community connecting, and that could really encourage that. And then you trust the source, and that's what I think would be really the most influential way to do that at this point.
Yeah, I think that's really key, right? The trust building, like you said, it's bad publicity is a huge effect on the space. Also, just looking from a business standpoint, and Jacob, on your end, do you have recommendations on the number of beds per certain, population numbers? Does it make sense 30 beds for 100,000 people? Do you ever look at those numbers when you're doing site location?
So I don't, based on geography and per capita, like if it's a bigger place, do you need this many more beds? I don't ever look at it that way because I haven't seen any sort of rhyme or reason to that. I've seen places with very low population but very high bed count because they're serving, say, Medicaid, or because they're just a great place that people want to come to, or vice versa. Some place with a ton of population and yet very few beds, but it may stay full for a whole different, basket of reasons, such as their clinical expertise, et cetera. That's really where I was going to mention there when Kathy was talking, was some of this feeds back to our conversation a few ago about outcomes. Why you were saying, if you have this many beds, how are you going to tell me there's not enough people there? Well, if we look at Southern California or Southern Florida, where you can't, throw a rock and not hit a couple of treatment centers, but you've got some place in the middle of the country with none of them, why wouldn't more people want to go to that one in the middle of the country somewhere? Well, they would if we knew exactly who had the best reputation for getting treatment done correctly and keeping people off whatever their issue might be. I think a lot of that localization will be driven and fed by that in the future, right? How successful are you? And so then it's not necessarily an issue of I need to be in this great destination place or whatever. It's going to be, I need to be where the problem is, but wherever I am, if I'm doing a good job, people are going to come, whether that's my local community that I'm involved in or whether that's from all over.
That's interesting. We got Kent Farr that does a lot of advising for us, and he used to work with Hazelden and a lot of the larger centers way back in the day, right? So I'm talking like 30, 40 years ago, he was doing this work. And, he always said the same thing. He's like, I'd go into these treatment centers that were struggling, but it was all community-based at that time. And the two issues were always just one, lack of community integration, right? People were not going out into the community. And then the second piece was actually the people on the phone, right? So they weren't building a good reputation when they actually connected with someone. So someone did reach out to them, but, they were given a very poor experience or a negative experience once that initial contact was made. So that's interesting. James, anything on your end in terms of what you've seen with clients?
Yeah, well, a couple of things. I'm out here in the West where we're not as densely populated as many of you are. And so, or a lot of the facilities either in California or back East. And there is a need. So there is a need. And I'll just give you an example. When I was the marketing director at a facility here in Utah, Jackson Hole, Wyoming had a tremendous need for support. And what we did is we identified that we could help. I mean, you're talking about, I don't know if you know anything about Jackson, but it's kind of in the middle of nowhere. It's not close to any major city. Salt Lake City's like 4.5, 5 hours away. And so building that same sense of community, Kathy, that you were talking about in Jackson Hole was super effective, but it was also filling a vital need for that community that's not very big, but building that community sense, even though it wasn't in our backyard, was really helpful for both them, and it certainly paid off from being able to serve a lot of the clients in that community. So I don't know if it necessarily has to always mean geographic. I think having a better understanding of where are you at and where can you build that community, even if it is 4 or 5 hours away, because the need is there. So I don't think we need to get so far into the box. Be open to going back to, yes, you're going to hear it again. What does the patient need?
It's an interesting comment. Something I see with clients, I think I see in this field all the time, is what I call chasing the policies, right? So rather than looking at what the patients need or looking at an area of need and then building your business to serve that, and that might be Medicaid or it might be PPO or whatever it is for a certain geographic area. But intent people send, okay, here's a good policy, let's market over there. I think that model needs to be flipped because obviously it has not been working, right? You get in there, everyone flocks to it, and then the insurance company gets upset and they cut the benefits. So, it works for a little bit. But the reality is that you should be looking at, as James was saying, what are the needs of the patient, what are the needs in the area, and then how do we build a good business to serve them? Comments there?
Yeah, I've got a question for you guys there, kind of along those lines. Feeding back into the whole thought of addiction of any sort being the stigma that it is. It's not a disease, it's a decision, right? And all the way it has been in the past. So that and like shame-based type treatment, how does that affect localization? I mean, like there's plenty of people I'm sure that don't want to get treatment in their town for fear of people judging them, seeing their therapist out at the grocery store, et cetera, all the other things that, I don't know, could go through their head. How does that affect the localization in the future, or how do they combat it? How do we as an industry combat that?
I'll jump in. I mean, I think it's a really good question that I ask. So I was just over at a clean slate facility here that moved in close by us, and they're right on a main thoroughfare, right? And so that's the question I asked the director is like, well, have you seen, negative effects from that about people not wanting to be seen coming in, things like that? And they had not. And they said that was kind of a consistent experience is people wanted treatment bad enough. Like if you're willing to get into treatment, you've made that decision, you know that you're ready, right? So she said that they weren't seeing it, but I'm sure it's a reality, right? I'm sure it's something that people are gonna be concerned about. And I think about it more from like the higher end facilities, right? If you got private pay parents, upper class, they tend to be very concerned about image, and a lot of high-end parents won't even allow for insurance payments because they don't want that on their child's record, right? I've seen that pretty consistently. So I think it depends on what demographics you're talking about. But at the same time, there's an understanding that I think a good facility will have discretion and, maybe not be blatantly blazing that, hey, we're a treatment facility. Everyone that's coming here is struggling with something. But I don't know. Yeah, that's my thoughts on it.
One of the things I would say to that too, Jacob, is, my encouragement would always be, let's put you here close to home. The support system will be, that continuum of care is going to be better, et cetera, et cetera. But I think sometimes we have to meet them where they're at, and maybe they have, if it's going to hold them back, then again, going back to that idea of, well, let's find, there are several options. And so you start with, it's kind of like what my dad told me when he started to show me how to work on cars. Start with the simplest stuff first, right? Whatever is the easiest solution, look there first and then go deeper and deeper and deeper until you actually find and can address that problem. I would say the same thing here, that there is stigma somewhere, and it brings up, I was in a meeting this morning with a very nice gentleman at a very big company that oversees literally hundreds of thousands of people. And I was talking to him about how we more effectively address addiction in the workplace. And his first comment is, well, I don't really relate with that, but let's sit down. Fast forward 45 minutes and building trust, he started to share about a family member, very close family member that's actually struggling with addiction. So some of that is us, and this is why that community thing, and I love this topic, of being able to really build trust with the community is going to break down those walls.
Yeah, I'd agree.
There's something that you said, James, about meeting people where they are. So one of the things that we have to do in this industry is change what we believe is the standard treatment. So the community option helps with that. So that idea that someone could start in outpatient and then they could move to residential if they need to, and that may be a detox stay only. And it allows that dynamic to work a little bit more effectively than being out, completely removed out of pocket. I don't know. I think it creates that opportunity, and I mean, we do both, and I think it is what works for each person. But I love the idea of someone being able to move freely with the same type of care, the same standard of care.
Yeah, I think that's important. Something else I would say in my experience to your question, Jacob, is, I'll attend parent groups like PAL or Al-Anon in the local community here. I've never heard the concern voiced about sending someone locally. And in fact, most parents will send someone locally first, but we don't really have residential options here where I am. We have like a detox and then you have outpatient. And so parents don't know where to send people, so they'll send them to what's available first. It won't work, and then they'll search for something different or something they hope to be more effective. But most parents that I've talked to send their child out of state or send their loved one out of state just because they don't know where else to go. That's who they found online. That's who was recommended to them by someone that they know. So they're only going out of state because there aren't good local options. If there were good local options, I think they would stay here most of the time.
I'd agree. I mean, I see the business transitioning there all the time. When I see what people are looking for, not the patient, but the businesses looking to grow and looking to expand. And there's no doubt that the local community is the biggest help that you can have. I was just curious about the way that the industry has been in the past, the stigma of it, that I wonder how many people are hesitant of localization or scared to be in their same area. But that makes sense. I mean,
well, I think, like Kathy's saying, you have to be involved in your community, and it's our job. I mean, it's part of our mission to, I think, eliminate that stigma as much as we can, right? So part of it is getting into the community and saying, hey, this is okay, this happens. We're here to help when it does, and let's make sure that we're not stigmatizing each other if this is a situation that's coming up for someone that we know.
Agreed.
Well, and isn't it interesting too? I think we've built the narrative, right? As an industry, we've built the narrative that, oh, you need to travel across country, or it needs to look like this, or you can have cell phones or you can't have cell phones when you're in. We built that entire narrative.
Yeah.
So we can reframe that narrative, and laws are helping us, right? They're nudging us along to maybe reframe some of that narrative too. But it's, I talk a lot about aligning expectations and aligning or sharing with people and being transparent about what that is. But you can create that narrative. Like, we're creating the narrative right now, right? I mean, the narrative around localization. So it's more about us committing to what's probably the right thing to do, and then building out from there on a new narrative that maybe that isn't, that's just not the way that we have to do it, maybe in some cases. But I think it's our responsibility, as you're saying, Nick, it's our responsibility to reframe that, because, hey, we've all been there. We've all heard people, they're in crisis. They're kind of going to just go the way that you direct them most of the time. So why not just rebuild that narrative in doing the right thing?
I agree. I mean, it's always ironic, right, from the marketing perspective, that we do tend to build the narratives that help our business. And so for a long time they did. But, again, if you look 20 years ago, there were no flyaway centers, right? The only flyaway centers that existed were for very upper class families or celebrities or cash pays that definitely didn't want to be seen, right? But for everyone else, it was community based. It always had been. And so I think it was a trend away, and it should trend back, I think, based on what's best for the patients. I think an interesting question too that I want to jump into and get everyone else's perspective on it. But like you said, the laws are kind of pushing this way. Insurance is pushing this way. I think publicity and the clients are pushing this way. But we've also seen it like on the Google end, right? Google is localizing your search results more from an algorithmic perspective. And so, all these centers used to use these directories and try and rank in all these states. I mean, we've taken on so many sites where there's just like pages for every single state in the country. But Google is de-emphasizing all of that now, right? So Google's pushing it away too. But any other comments on things people have seen kind of from the marketing space that is also forcing our hands in this direction?
I'd like to comment on that because it's been interesting. We did decide to go with a local marketing strategy, and the one place I've seen the most impact on has been the Google ads. So it's definitely a different set. But what we did prior to that was we did heat maps of where our patients come from. Just where do they traditionally come from, and is that the biggest area of need? And then kind of use that Google ad localization. And I have definitely seen that work. I think the BD is a long game. You have a lot of time you got to work into building in the community and building trust. But it was interesting. It's not like it's a huge spike, but it was very clear that people were coming from those areas.
Yeah, I see that with the AdWords a lot too, in terms of localizing it. It's cheaper, but I think connecting to James, a lot of what you do is you need a different skill set on the phone to get someone to go across country if they're going to pay for that own plane ticket, right? So when you're localizing campaigns, whether it's SEO or AdWords, is your call team even good enough to get people to travel the distance, right? Oftentimes they aren't. So, it just makes more sense from that standpoint to have someone of a different skill set be able to arrange transport, for example.
Can I just add one more note too? I think the really important thing about our approach in marketing for the local view is that we do have to do a lot more education. So like in breaking the stigma, those community impacts, it's a different way to market, but it's certainly a very important way to market. Even just getting on TV and saying, being able to answer questions about people going into treatment in one of those little 8-minute spots or whatever, after a news channel or something like that. Those I think are an educational source that we can get back with and will again help build that trust, I think. Versus just running a commercial across the world.
Yeah, right. Right.
Yeah.
James, Jacob, comments?
I don't have one. I'd agree with that wholeheartedly. The education is the biggest piece, and building that community, and then getting everyone engaged and understanding that it's a normal thing. Everyone's affected by it. That heat maps point from Kathy is interesting to me from my field. Just wondering if I'm a center that's fairly large, or has some resources and some success. If I see that 75-80% of my clients come from one area, would I move my center there, or buy a center there, open a center there? I mean, that's an interesting concept to me from what she was saying, to figure out exactly where they're from. And are we doing a good job of bringing them from there, or is it more advantageous to just go there or open something there? It's interesting.
Yeah, it's certainly, for me, one of the most interesting parts was all the people from like northern Michigan going to California. And so I said, why? Why is it? Well, I can understand that, but really the question really came down to is the insurance provider, what insurance provider could be accepted. So, and then the other part is just that idea that in certain communities, it is more difficult to heal in your community. So it's just fascinating. I do think that when you do those heat maps, you have to turn around, ask all the questions as to why people are coming from that area and how underserved it is. And I think it speaks to what you said. Do I put a treatment center there because that is underserved? And then do I set it up for that success? Yeah.
Very interesting. All right, guys. Well, appreciate the time as always. And I think our listeners, we're excited for you to join us here. Make sure that you check out Treatment Trends, hit that little subscribe button, so you get notifications when we have a new episode. And we'll be looking for you next time.
All right. Hey, bye
Bye,
everybody.
Thanks, guys.